Good morning, everyone. I'm pleased to announce Sreevathsa Kadaba with his talk about ccTGA surgical options. I hope it will be much more clear after his talk. Please, Sri.
All right, Oleg, thank you very much. So today's discussion talk is about ccTGA surgical options, as Oleg has told. Thankfully, it's not that what we do and what we have to do thing, because there's nothing great that we can do other than what is actually described in books for ccTGA. So I'll give a brief introduction about the pathology and then go ahead with my slides. As we know, ccTGA is known by other terminologies. It's called either an isolated ventricular inversion, double discordance, or a physiologically corrected TGA. The reason being there is a discordance between the atrioventricular connection, the right atrium is connected to the left ventricle, and the left atrium is connected to the right ventricle. And there is a ventriculo-arterial discordance as well, where the left ventricle is connected to a pulmonary trunk and the right ventricle is connected to the aorta. So that's why it's called as double discordance, and it's also a physiologically corrected TGA because the pulmonary venous, the systemic venous blood that enters the right atrium is still going to the lungs via the left ventricle, and the pulmonary venous return that's coming from the lungs into the left atrium is still going to the body through the aorta, though it is passing through a different channel. All these names are not universally accepted. However, congenitally corrected TGA is an accepted terminology. And as we know, it's a rare congenital anomaly. It's just 0.03 per 1,000 live births. That accounts to 0.05% of congenital heart disease, and we know it's quite a small number. We had extensive discussion about the history, embryology, and the diagnosis, the investigations for ccTGA. Thanks to Bernie for that talk. Today, we, however, will go ahead with knowing a bit of applied anatomy of ccTGA, how it really affects the surgical management and the associated defects associated with ccTGA and how it affects management as well. As I've already told, it's called a double discordance. So the systemic venous return is pumped into the lungs again, and the pulmonary venous return is still directed to the body. There are associated malformations with the congenitally corrected TGA, and the most common associated malformation is what is known as the triad of malformations in ccTGA is the interventricular communication or the ventricular septal defect. There is an obstruction to the outlet from the morphological LV, that's a pulmonary stenosis, and there are anomalies of the morphologic tricuspid valve, which are quite a few numbers to enumerate, which all either in combination or alone will affect the outcomes of the condition. Now coming to the ventricular septal defect, the ventricular septal defect is present in nearly half of patients with congenitally corrected transposed great vessels, and usually the defect is a perimembranous ventricular septal defect. As you can see here, this is a pictorial representation of the various ventricular septal defects that can happen in a congenitally corrected TGA. You can see the right atrium here. Through the right atrium, it goes across through the mitral valve into the morphological left ventricle, which is on the right side here, and it is connected to the pulmonary artery. You can see these various red dots. These are the ventricular septal defects that can occur. The most common one is the perimembranous defect, which shows is in continuity with the pulmonary valve and the mitral valve, can have more of an inlet extension. There can be an isolated ventricular septal defect in the muscular inlet, or it can be a doubly committed ventricular septal defect, rarely where it is more committed towards both the great arteries, or there can be isolated muscular ventricular septal defects either in the mid-muscular cavity or in the apex of the right ventricle. The reason why we have to know about these ventricular septal defects is in conjunction with how the bundle runs across the ventricular septal defect. I'll come in detail about the bundle in the next few slides. Then we have the left ventricular outflow tract obstruction. That is also the pulmonary stenosis, because at the outflow of the left ventricle, there is the pulmonary valve. And this pulmonary stenosis occurs in 1/3 of patients who are having ccTGA. And usually it is associated with the presence of a ventricular septal defect, or it can be an isolated pulmonary stenosis rarely as well. Usually the triad of combination occurs together. They have a ventricular septal defect, they have a pulmonary stenosis, and tricuspid valve abnormality. As we can see again here in this picture, that this is the area where the pulmonary stenosis happens, and the pulmonary stenosis can either be valvar, subvalvar, or in rare occasions can be supravalvar as well. The valvar pulmonary stenosis may be a small perforation in the pulmonary valve, or it can be a bicuspid pulmonary valve, or it can be muscular tags that are present in just below the pulmonary valve, or it can be a large muscle bundle that obstructs the pulmonary valve, as in case of a tetralogy of Fallot as well. Again, we have to know that it is closely related to the bundle. Any excision of the pulmonary muscle bundle or pulmonary stenosis should be in conjunction to know the in conjunction with the bundle's presence. The other triad is the tricuspid valve. The tricuspid
Sri, we can't hear you. Sorry, Sri just have to change his headset. 1 second.
Oleg, am I audible now?
Yes, we can continue.
I'll continue with the present slide. The next triad is the third component of the triad is the anomalies of the tricuspid valve. It is usually Epsteinoid malformation. Now, why we call it Epsteinoid and rather not an Epstein's malformation is that it's not a true Epstein's kind of anomaly. The septal leaflet and the posterior leaflets are displaced more apically. However, there is no typical anterior sail-like leaflet which we can use for repair or which is present in the usual Epstein's anomaly. And also there is no typical displacement of there's no particular demarcation of the atrialized portion of the right ventricle also in ccTGA with an epsteinoid malformation of the tricuspid. Along with the epsteinoid malformation or other than the epsteinoid malformation, there can be overriding or straddling of the tricuspid valve, which will quite significantly affect the way we are going to treat or operate on a child with CCT. If the overriding or straddling is quite significant, there can lead to hypoplasia of the right ventricle, which in case is known as the double inlet left ventricle, which totally changes our management pattern. Along with this triad of malformation, there can be other abnormalities as well. There have been rarely reported right ventricular outflow tract obstruction or subaortic stenosis, which is quite rare in fact. They can have abnormalities of the mitral valve, like clefts in the mitral valve or deformed or mitral valve prolapse as well. In few cases, there can be straddling of the mitral valve chordae, very rarely though, and this can lead to a double inlet right ventricle kind of physiology and a very small or hypoplastic left ventricle with a dominant right ventricle, which again changes the surgical options. So now coming to the conduction system. Now, why we are stressing so much on the conduction system is the conduction system in ccTGA is not in the usual pattern as it is a normal heart or in case of a heart with a regular perimembranous VSD. Why is the abnormality in the conduction system? Now, there is a reverse offsetting of the valves. That is, the mitral valve is a bit higher as compared to the tricuspid valve as compared to the normal heart, where the tricuspid valve is offset more. There is a fibrous continuity in ccTGA between the mitral valve and the pulmonary valve. You can see this is the normal fibrous trigone in a normal heart. We can see here that this is the right side tricuspid valve, left side mitral valve. This is the aorta, and this is the pulmonary artery that is quite away in the right ventricular outflow tract. And you can see here that the continuity between the mitral valve and the aortic valve. Whereas when you see in case of a ccTGA on the right side in picture B, you can see that on the right side it is the mitral valve, and the left side is the tricuspid valve, and the pulmonary artery has continuity between the mitral with the mitral valve, not the aorta in this case. As you see here, because what happens is, because the pulmonary valve is wedged between the ventricle and the mitral valve and the atrial septum, there is a fibrous tissue that fills the gap between the pulmonary valve and between the atrial septum and the ventricular septum. Now, this is the place where the regular AV node has to seat it, that is in the triangle of Koch. In many cases, there may not be a normal AV valve in the apex of the triangle of Koch, or even if there is an AV valve in the apex of the triangle of Koch, it cannot penetrate the membranous septum that is present between the atrial septum and the ventricular septum, and hence does not make a connection with the bundle. In case of ccTGA, there is always, or most of the times, an abnormal or a second AV bundle or AV node which is situated more anteriorly, and this anterior AV node is the one that gives the bundle, and then which goes and pierces the fibrous septum and then continues as the bundle of His. As you note here, that the bundle has to travel a long path along the pulmonary valve, anterior to the pulmonary valve, and then subsequently anterior-superiorly to reach the ventricular septum and divide into the bundle. Now, this unusual long pathway is the reason why where the patients are predisposed to develop bundle branch and more of conduction abnormalities in a patient with TGA. Here we can see another representation of the same AV node. This is the more anteriorly situated AV node. We see that this is the triangle of Koch, which is bordered by the tricuspid valve. In this case, is the mitral valve, the coronary sinus, and the tendon of Tadaro. There is no AV node here, or rather not represented. It may be present. It does not make connection with the bundle or does not pierce the septum here. And then this AV node goes anterior to the pulmonary valve and grows in close relation to the right ventricular or the left ventricular outflow tract and the ventricular septal defect, and then branches into the bundle as normal. Here you can see its close relationship to the ventricular septal defect as well. This is the anterior superior aspect of the ventricular septal defect, as we are seeing through the right ventriculotomy, left ventriculotomy incision in this. This is the right atrial incision, and we are seeing through the mitral valve. The other applied anatomy that we need to know very importantly in a ccTGA is the anatomy of the coronaries, because this is the age when in this era we are doing a lot of double switch. Really?
Sri, we can't hear you again.
Yeah, no, I've stopped talking because there was some problem with the volume of the mic. I'm checking if I can increase it. No,
can you hear us, Sri?
Yeah, you can hear. I can hear you clearly.
Excellent.
Now, am I audible more?
No, speak up.
Am I audible more now? Better?
A bit more, yeah. A little bit better, but not much. You can improve more.
No, it's 100 on the mic here.
Better, that's better. That's better.
Okay, I'll talk like this, much closer to my mouth, the mic much closer to my mouth. All right. Sorry again for this disturbance. No. I'll start sharing the screen again. Okay, is my PowerPoint screen visible now? Should be.
Not yet.
Not yet. I am on. I'm sharing it now.
It's not coming across.
Oh.
Yeah, it's fine now.
Yeah.
But this is not the presentation. Can you see the PowerPoint presentation slide? Yeah.
Yeah, it's not full mode, but we can see.
I don't know because I stopped. Maybe there's a problem with. I'll stop and rejoin again. Don't mind. Sorry, this happens. Okay.
Yeah, it's good now.
We can't hear.
Sri, you're muted.
Now.
No. Yeah, carry on.
Okay. So now I think they're audible now. So we have to know the applied anatomy of the coronaries in ccTGA. In ccTGA, as we know, that it is the exactly opposite ventricular morphology as compared to the normal heart, and as we expect, the coronary morphology also will be opposite to that of a normal heart. Here we can see that a person standing in the non-coronary sinus of the non-facing sinus of the aortic valve, if he stretches his hand, right and left hand outwards, the one on the sinus on the right side is the sinus 1 that morphologically should give a left coronary artery in a normal individual, but in case of a ccTGA, that will be the morphological right coronary artery because the right ventricle is on the other side. Whereas the left hand sinus, which is the sinus 2, which should have normally given the right coronary artery in a normal individual, is now giving rise to the left coronary artery, which branches into the left anterior descending and gives to the right circumflex rather than calling it the left circumflex artery, and goes behind the mitral valve to behind the mitral valve. Now, the dominant circulation is the morphological right coronary artery, which passes behind into the posterior interventricular septum and gives rise to the interventricular artery, that is the posterior descending artery in most of the patients. Now, why we need to know this is important in case of transfers of coronary when we are doing double switch operations in these patients. Along with this abnormality, they can have various other combinations like a single coronary artery, or these coronary arteries can arise individually from individual sinuses. They can have an intramural course, they can have a muscular course as well, or they can have anomalies like short left mains, which is quite difficult or challenging when we are doing a double switch operation. So what is the natural history of a patient who is having a congenital corrected TGA? Now, the natural history of the ccTGA always depends upon the function of the systemic right ventricle, the presence or absence of associated anomalies. Now, in the presence of in the absence of anomalies, usually the patients the, usually the outcome of ccTGA is considered to be unfavorable, though there are reports of patients who are living up to 5th decade or 7th decade, up to 5th decade with associated anomalies, or up to 7th decade sometimes without associated anomalies. However, this is not a life that is free of complications or free of problems. They definitely have a lot of symptoms, and they don't have a normal or a good quality of life up to this age. Now, why does the life is not, why is the quality of life not normal? Because the RV starts failing as the patient ages. Now, why does the RV fail? The RV does fail because the RV is the systemic ventricle here. It is supporting the systemic outflow, and this, as we know, the right ventricle is not as competent as the left ventricle. There are morphological differences. There are microscopic differences in the right ventricle and the left ventricle myocardium. The left ventricle myocardium, as we know, is more helical and is structurally much stronger as compared to the right ventricle. And hence, when the right ventricle is exposed for a longer time to the systemic afterload, this right ventricle develops hypertrophy. And now, as the right ventricle develops hypertrophy, it is still supplied by the single right coronary artery, and this single right coronary artery supply is not enough to sustain the requirement of the hypertrophic right ventricle, and hence there will be coronary perfusion mismatch, and gradually the right ventricle will fail. There is also the tricuspid valve that is present as a systemic valve, and we all know the tricuspid valve is a trileaflet valve and is more liable to fail as compared to the stronger mitral valve, and hence in this case as well, the tricuspid valve can fail and lead to regurgitation, and gradual worsening of tricuspid valve regurgitation will again cause a volume overload on the systemic right ventricle, and hence leads to right ventricle failure. And also, the bundle has to cross a longer path in the fibrous septum to reach the and then further go on to branch into the bundle of His. And there can be a lot of fibrosis over the ages, over a few years of duration, and hence because of this fibrosis as well, there can be complete heart block in patients who are unoperated as well. Of course, when we are operating on patients, these patients can still develop complete heart block, and hence they can have problems further. Now, why do we have to operate on patients on with ccTGA? Because we have told that the ccTGA is a corrected anomaly. It's physiologically correct. The pulmonary supply is normal. The systemic supply is normal. Why do we still have to operate on these patients? Now, this is one condition where historically the diagnosis of ccTGA per se is not an indication for surgery, unlike other cases where we would say that the diagnosis of a congenital heart defect would itself be the indication for surgery. However, with the present trend of better surgical outcomes and improved techniques in surgery, this indication may change, and over the few years of time, diagnosis of ccTGA may still be an indication for surgery per se. Usually now, the hemodynamic impact of the associated lesions is what forms the prime indication for surgery. Right ventricular function that is liable to reduce over a period of time, a right ventricular failure hence is a prime indication for surgery. If there are associated lesions like a ventricular septal defect, we need to know the flow or the QPQS. Depending on the significance of the size and site of VSD, we can embark upon surgery. If there is pulmonary stenosis, again we need to assess what is the gradient across the pulmonary valve, how significantly is the pulmonary stenosis affecting the patient, can he live with a mild pulmonary stenosis for a longer time, or is he having significant pulmonary stenosis and thus having cyanosis, hypoxia due to pulmonary stenosis, and also complications due to hypoxia like polycythemia and other complications. Next, we have to see how significant is the tricuspid regurgitation. Is the tricuspid regurgitation mild? Will it sustain for a longer duration, or is it moderate to severe? And leaving a tricuspid regurgitation will accelerate the right ventricular dysfunction. And hence, TR stands an important indication for surgery at the present moment. So, what are the repairs that we aim in ccTGA? The surgical options for ccTGA is do a physiological repair, mean to say that the associated cardiac lesions only are corrected, the atrioventricular and the ventricular arterial discordance are not touched upon. Other way is we do an anatomical repair where the morphological left ventricle becomes a systemic pump and the morphological right ventricle will become the pulmonary ventricle, and hence is much better anatomically. Now, there are various arguments, plus and minuses of physiological repair or anatomical repair as well. Now, coming to physiological repair. As I said, in the physiological repair, the atrioventricular and the ventricular arterial discordance is not touched upon. only the associated lesions are treated. Most common lesion is the VSD, and hence the most commonly performed surgery in physiological repair is a VSD closure. The next is VSD closure with a pulmonary stenosis repair, and the other one is the tricuspid valve repair. Coming to VSD closure, we all know that VSD closure is now regularly done through a right atriotomy. Earlier for ccTGA, VSD closures were done via incision in the left ventricle or in the right ventricle. Now most surgeons have abandoned ventriculotomy incisions and regularly going through the right atrial incisions to close the VSD. This picture shows a surgeon's view when he is standing on the right side of the patient in a supine patient. This is the superior vena cava entering into the right atrium, and this is the inferior vena cava entering into the right atrium. At the right atrium, at the mouth of the right atrium, there is the mitral valve. This is the most important difference. It should be a tricuspid valve here in a normal heart. We can see here it is the bileaflet mitral valve, and to the right side of the patient is the morphological left ventricle associated with the mitral valve, and on the other side we can see this is the right ventricle, and the left ventricle is giving rise to the pulmonary artery, and the right ventricle is giving rise to the aorta. Now, in VSD, what we are going to do is we usually approach the closure of ventricular septal defect through the right atrium. We open the right atrium. We either go through the mitral valve by retracting the leaflets of the mitral valve. However, the problem with retraction of mitral valve here is, unlike the tricuspid valve, which has 2 leaflets here, or 3 leaflets, where we have a smaller leaflets and easier to retract, it is difficult to sometimes retract the mitral valve. So we may have to make an incision on the base of the leaflet of the mitral valve, and then open up the mitral valve, and below this mitral valve will be the VSD, which has to be closed. Here we can see that all right. When closing the ventricular septal defect, we have to be careful about the conduction system, as I've already mentioned. We can see here the conduction system is not in the AV node. It will be somewhere anterior, and it passes anterior superior to the ventricular septal defect. Now this dotted line is the pathway where the bundle is crossing, and we need to be careful of this bundle. How do we take care of this bundle? Usually we take sutures from the left ventricular aspect of the ventricular septal defect, partial sutures on the left ventricular aspect, either continuous or most likely interrupted. Taking interrupted sutures usually causes less problems for the bundle or causing complete heart block postoperatively. Now, as we come along from the anterior-superior aspect, we come to the annulus of the mitral valve, and then we can use continuous sutures to close the mitral valve, close the VSD across, close to the mitral valve annulus. Now, this is how the patch seats, and when we see in the cross section, usually a ventricular septal defect should sit on the same side of the ventricular septal defect, the patch, whereas in case of a ccTGA, we see here that on the superior aspect, that is close to the mitral valve annulus, it is sitting on the left ventricular aspect, and as we go down to the anterior-superior margin, we see here it is going down through the VSD into the anterior-superior aspect of the VSD. It goes towards the right ventricle, and we can see here that the bundle is avoided. So what is the precaution that we need to take? We need to take sutures on the right ventricular aspect, and we need to take sutures either 3 to 4 millimeter away from the bundle, or if we are taking close to the bundle, then take bites that are not through-on-through bites, and take it only on the right ventricular aspect rather than coming on the left ventricular aspect. Now, historically, VSDs have been closed through the aorta as well. I don't have a picture where the VSD is shown through the aorta. If it is a big aortic valve and we can retract the leaflets and go through the aorta, it is better, because there is we are less liable to injure the bundle when we are going through the right ventricular aspect, because the bundle is on the left ventricular side, and taking bites on the right ventricular aspect is easier. But the only thing we need to be taken care of during closure through the aorta is not to entangle the tricuspid valve that is on the right ventricular side. Next associated lesion is the pulmonary stenosis, which I've already mentioned is usually isolated valvular pulmonary stenosis. A valvular pulmonary stenosis can just be treated with a pulmonary valvotomy, with an incision on the PA, and the PA incision can be closed via a patch on the pulmonary artery. However, easier said than done. The pulmonary artery will be usually posteriorly located to the aorta, and directly approaching the pulmonary artery to do just a pulmonary valvotomy is difficult, or more easier said than done. There can be a subvalvular membrane which can be excised as well, or if it is a pulmonary stenosis because of the membranous septum aneurysm, this can be excised via the right ventricular right atrial incision, or more significantly, if it is a muscular stenosis or muscular bundle that is muscle bundle that is causing pulmonary stenosis, we can excise the muscle bundle. Now, we need to be more careful when we are embarking on surgeries where we are excising the muscle bundle. Never remove the rightward aspect on the right side of the left ventricle. Now, the left ventricle we can see here, this is the place where the pulmonary stenosis will happen. And if we are overzealously excising muscle bundle at this point, then we are still liable to damage the ventricular septal, the bundle that crosses close to the pulmonary muscle bundle that runs over there. So now, if the pulmonary stenosis is significant and we cannot do anything to the valve is quite low on its Z-score, then either we can place a valved extracardiac conduit. The extracardiac conduit depends upon the availability of the extracardiac conduit, and we have already discussed about the various extracardiac conduits that are available. Now, what has to be taken care during placement of extracardiac conduit? We have to be careful about the site where we are going to make the incision, because it is the left ventricle that is on the right side, and when we are incising, we know that the papillary muscles of the mitral valve are on the free wall, not on the septum. And when we are making an incision on the free wall of the left ventricle, we need to be sure that we are not damaging the papillary muscles to the mitral valve. There can also be a coronary branch that is crossing the outflow at that point. We need to be careful about the coronary branching, which is usually the major coronary vessel or the left anterior descending artery. And also, placing a conduit in a congenitally corrected TGA is not straightforward. The conduit can easily be compressed by the sternum because it is more anteriorly placed, and it can be easily compressed by the sternum, and hence either we have to place the conduit more towards the right side of the chest, going lateral to the right atrium, or in cases where we are doing a conduit from the other side, where we are routing ascending or a rastelli or surgery like that, then we have to place the conduit more laterally on the left side. Usually delayed sternal closures help in these patients after conduit repair. Now, other anomaly is the tricuspid valve. What do we do for the tricuspid valve? Now, tricuspid valve is not as easily approached as in a normal heart, because we know that it is most posterior and it is more apically displaced, or more it's more oriented downwards as compared to a tricuspid valve in a normal heart. And usually the defects in the tricuspid valve will be more dysplastic, or the clefts or the anomalies will be significant, and hence most likely we won't be able to repair a tricuspid valve successfully, though there are repairs of tricuspid valve that have been reported in quite a few number of papers. But the long-term outcomes are not good. So the most of the cases end up with replacement. Again, the choice of valve for tricuspid valve replacement is based upon, as usual, for any other valve replacement. What are the outcomes of these physiological repair? Why can't we just keep on doing physiological repairs? Because though there are low early mortalities, it is surgically simple. It has been proved that the long-term outcomes of these physiological repairs are bad. The RV, which is still systemic, will continuously progress to deteriorate, and hence it is not an optimal surgical outcome. What are the risk factors that determine poor outcomes of physiological repair? The presence of an epistenoid malformation in tricuspid valve. If you have to do a tricuspid valve replacement per se in the first go, the right ventricular function is already poor in the preoperative condition. There's already a complete heart block in these patients, or the subvalvular PS is quite significant, then the outcomes are poor in a physiological repair. So what is the other option? We can do an anatomical repair. In anatomical repair, we are going to make the right ventricle the pulmonary ventricle and then convert the left ventricle into the systemic ventricle. Why is it better? Because the morphological left ventricle is better prepared to take the systemic load after the surgery, and is less liable to fail over the long-term duration. However, we are not very sure about this outcome as the long-term outcomes of anatomical repairs are not yet available in large numbers. You can consider what precludes the anatomical repair. It will depend upon the balance of the ventricles. If there is a condition like a DILV or a DIRV with a hypoplastic right ventricle or a hypoplastic left ventricle, significantly bad atrioventricular valve, then that precludes anatomical repair. We need to be sure that the ventricular septal defect is really rootable. If it is a remote ventricular septal defect which is not properly rootable, then that again precludes anatomical repair. Not just that, the anatomy in ccTGA is not always the same. There can be various positions of the heart which can make the surgery difficult per se. Cannulation can itself be difficult in a heart where it's mesocardia with the posteriorly located SVC and the IVC, unapproachable right atrium or the left atrium to do the valve replacement. There can be coronary anomalies which cannot be straight, which may not be straightforward, but with increased surgical experience, there are not many coronary anomalies that can't be tackled nowadays, but still it stands to be a significant risk factor and hence stands a contraindication or a relative contraindication for an anatomical repair. What are the anatomical repairs available? It is either a double switch operation or an atrial switch. Double switch operation means to say there is an atrial switch operation combined with an arterial switch operation. Or we can either do just an atrial switch operation and a ventricular rerouting of the ventricular septal defect into the aorta and then do a rastelli. I'm going to come to details. We will look into the surgical options of surgical techniques of double switch operation. The first part of the double switch operation is the atrial switch operation. In atrial switch operation, there are two kinds of surgery: Senning's repair or a Mustard's repair. First, I'm going to show you pictures of Senning's repair. Here, this is not the exact picture of a ccTGA. Don't look at the other anatomical feature here. This is for TGA. Here you can only see the right atrium and the Senning's portion. This is the SVC, the IVC, right atrium. A right atrium flap is made on the wall of the right atrium. It is retracted anteriorly. Here in this case you are seeing the tricuspid valve, but in ccTGA it is the mitral valve. Now, once the right atrium is opened, we are going to make an incision or a trapdoor kind of incision in the intraatrial septum. Any atrial septal defects that are present will be closed, and this flap will be taken back and sutured to the wall of the left atrium so that the pulmonary veins will be directed posterior to this flap. Once this flap is closed, we can see that the atrial septum that was made as a trapdoor incision is sutured to the wall of the left atrium posteriorly, and this incision is made posterior to the intraatrial groove to open up the left atrium. Now the pulmonary veins will flow from posterior through this opening in the left atrium. After this, we are going to baffle the SVC and IVC into the tricuspid valve, and that is done by suturing the posterior free wall of the right atrium into the margin of the valve here. We can see this is the mitral valve that is sitting anteriorly, and this is the tricuspid valve that is sitting posteriorly, and we are going to suture the free wall of the right atrium, posterior free wall, to the margin between the tricuspid valve and the mitral valve. Now that baffles the SVC and the IVC into the tricuspid valve. Secondarily, we are going to close the opening that is made in the right atrial wall, or the right atrial anterior free wall is brought posteriorly and anastomosed to the opening posterior to the interatrial groove, and thus the SVC and IVC is routed to the tricuspid valve below this flap, and the pulmonary veins go all along to the right side, travel a curvilinear pathway anteriorly and enter into the mitral valve. Now, the second surgery is the Mustard surgery. The Mustard surgery, though technically is considered much easier, but there are more complications associated with Mustard surgery. Here we can see the right atrium is incised, the intraatrial septum is totally excised, and the coronary sinus is opened up to the intraatrial septum. Then a pericardial patch is harvested. A pericardial patch is shaped like a butterfly in this case. It is more wider at the edges, almost half the size in the center. And this interatrial septum, the pericardial patch, is close sutured to the posterior wall of the left atrium and the septum between the mitral valve and the tricuspid valve. You can see here, this suturing is continuous, and this pericardium will reroute the SVC and IVC into the tricuspid valve, and the pulmonary veins, as you can see here, directly opens into the mitral valve, and the atrial septum, atrial incision is closed either directly or in case required, a pericardium can be used to augment the pulmonary venous chamber as well. Next part of the double switch operation is the arterial switch operation. The arterial switch operation, in which we are going to disconnect the aorta and the pulmonary arteries, do a Lecomte maneuver, harvest the buttons, transfer the buttons onto the neo-aorta, and then reconstruct the pulmonary artery as well. Now, what are the problems with there are various problems with the anatomical repair as well. We cannot do a double switch operation in all patients with congenitally corrected TGA. We have to sometime embark upon other surgeries like a Sennings with Rastelli. In patients who are having ccTGA with a VSD and PS, which is significant, a Senning with Rastelli is a reasonable option for surgery. Now, what guides the surgery is the presence of a routable VSD, presence of an adequate size VSD as well. If it is not adequate, then we have to enlarge the VSD, and of course, whatever surgery we do, it has problems associated with Rastelli, like conduit stenosis, conduit regurgitation, redo surgeries for these patients, so on and so forth. Now, this is an example or pictorial representation of a Sennings Rastelli repair. The Sennings portion is not shown in this image. It's only the VSD closure. This is in which what we are doing is here we have made an incision on the morphological left ventricle. The morphological left ventricle is open, and as we see here, the VSD is seen directly below. And here you need to take care that the bundle crosses posterior inferiorly rather than anterior superiorly. We are seeing it from the other ventricle, left side, but not from the right sided ventricle. We can use a large, generous baffle kind of patch, not a straight patch. Usually the patch is harvested or taken from a conduit, which more than 3/4 circumference of the conduit is used to create a large baffle that will allow an unobstructed pathway from the ventricle to the aorta. And then once the baffle is created, it can be closed routinely, or a Rastelli can be done. The other option is a pulmonary root translocation. The pulmonary root translocation is where the pulmonary artery, if it is not significantly stenosed or it is borderline stenosis, and we still feel that the pulmonary artery can be utilized to, rather than avoid a Rastelli or a conduit in patients, we can harvest the pulmonary artery from its root. The pulmonary valve is preserved, or in case we see that the pulmonary valve is not suitable to give a reasonable pulmonary valve, we can open the pulmonary valve. The hole at the opening of the pulmonary valve where we have harvested it from the root can be closed with a pericardial patch. The VSD can be routed to the aorta, and then a right ventricular incision can be made, and the harvested pulmonary artery can be anastomosed to the ventriculotomy. If the pulmonary valve is bad, then we can use a monocusp or a bicuspid pulmonary valve to maintain or to prevent regurgitation in the immediate postoperative period. We can use a pericardial patch to augment the opening into the pulmonary valve. This is a root translocation procedure for congenitally corrected TGA. Now, there are options where double switch operation is not very optimal, in which we need to combine these patients with a Glenn. Why we are thinking about combining a Glenn with a switch operation is because it reduces the complexity of the intraatrial baffle. We have already performed a Glenn. The SVC is already anastomosed. So there's no question of rerouting the SVC into the systemic baffle. So the baffle can be smaller. The complexity of routing the baffle is less because we have to only take care of the IVC routing, and we don't have to worry about the SVC. Obviously, the Glenn can be performed on a beating heart, and hence it reduces the myocardial ischemia time. And it also reduces the complication of a mustard or senning, like baffle obstruction or a sinus node dysfunction in the long-term period. When we are combining a Glen, the amount of blood that is going through the systemic venous baffle is less, and hence the amount of blood that is entering into the right ventricle is less. And when we do a Rastelli, the amount that is going through the conduit is less as well, and hence putting a reasonable sized conduit will last for a longer time in a Rastelli. Though of course it does not avoid the complication of stenosis, but the volume of blood still reaching the pulmonary artery through this Rastelli or whatever conduit we have put will be better. And also there is less blood that is reaching the right ventricle, and hence the hemodynamics are much better as compared to a larger volume when both SVC and IVC blood is reaching into the right ventricle, especially when the right ventricular cavity is small in few patients. What are the complications of surgeries for ccTGA? Whatever surgery we do, close the VSD, pulmonary stenosis excision, do a atrial switch, an arterial switch or double switch operation, the long-term data with all these surgeries are limited. Most of these reports a lot of significant incidence of complete heart block, as high ranging from 10% to 25%. Arrhythmias much higher than that. Significant left ventricular dysfunction in the long-term course. Aortic regurgitation, which is present even in arterial switch operations, not something new for these cases. Since we are adding on baffle surgeries in this case, you can have problems with baffles like systemic venous baffle obstruction when you do a Mustard's type of baffle, because it's a pericardial patch. If you don't take an adequate size patch, you can have a significant systemic venous baffle obstruction. Or when you're doing a Senning's obstruction, you can have a pulmonary venous baffle, because you need to make sure that the path where the pulmonary veins enter into the neo left atrium and passes across the intraatrial septum or posterior to the intraatrial septum and enters into the new left atrium, it has to be quite generous, and there are various techniques to augment this as well. And again, these surgeries are not devoid of problems associated with coronary anastomosis. We can have a lot of coronary problems, either short term or in the long term as well. As I said, all patients are not subjected to surgery in early life. Few of the patients will reach adolescence or adult age. By then, the patients may not be suitable for a double switch operation. Now, what can we do if you need to still go ahead with a double switch operation? There is something called as LV training by banding the pulmonary artery acutely over as it just comes out of the left ventricle. Now, the success of pulmonary artery banding for LV training is limited. It can take more time, as long as sometimes 6 months to 1.5 years time. The pulmonary artery band has to be in position to adequately train the left ventricle. There is no estimated guideline as to what has to be the adequate pressure of the left ventricle in order to say that it will sustain a complete repair or anatomical repair if we are embarking upon. But still, a morphological LV pressure of 70 to 80% of systemic pressure is taken as an adequate guideline to proceed with further surgery. Again, we need to echocardiographically assess the mass of the left ventricle. If the mass is sufficient, if they have a good ventricular function after the pulmonary artery banding, before the pulmonary artery banding, have a good posterior wall thickness, this all suggests to say that the LV has been trained adequately and we can do a complete repair or anatomical repair further go on. But the training of left ventricle is more successful as per reports in patients who are less than 15 years of age. As the age goes above 15 years, the success of this surgery is less and hence is probably not undertaken. The risk factors for a poor LV training even after PA band is if the LV is already dysfunctional before banding, the LV is already dilated before banding, and as I said, older age. This is not some surgery which is proven to be effective as well. Now, what can be done? If we are not doing a physiological repair, we're not doing an anatomical repair, the patient does not have associated anomalies, has lived to a longer age, maybe second decade, third decade, starts to developing failure features. Is it the end of the surgical pathway? Maybe, may not. can still have the single ventricle pathway, which is option in those cases, or the single ventricle pathway may be only option in cases which is complex with the associated anomalies like DIRV or DILV, where there is a hypoplastic ventricle and hence cannot be used for a biventricular repair. This routable, the VSD is quite large or a non-routable VSD. We can't embark upon a biventricular repair. It has to go for a single ventricle pathway. There are straddling as a DIRV or DILV. There is significant straddling or overriding of the AV valves that is repeated. So we have gone through so many options: anatomical repair, physiological repair, single ventricle pathway, for so many years now. But have we still found the perfect surgical option for ccTGA? No. The paradox of surgical management is the number of cases of ccTGA is so less that there's very little evidence to prove what is the best option for ccTGA. To do a physiological repair, it is easy. It can be done in many centers who are not regularly doing congenital cardiac surgeries, not experienced in these cases. Not many surgeons can boast that they are highly experienced in cases operating on ccTGA, but still physiological repair are supposedly much easier to perform, but they have suboptimal mid and long-term outcomes, though the early outcomes are very promising. What about anatomical repair? It is quite difficult. It involves two of the most difficult surgeries in cardiac surgery: an atrial switch operation, which is, though looks easy to perform, is technically quite challenging to do, and an arterial switch operation with a lot of coronary anomalies, great vessel abnormalities, the position difficulties, side-by-side great vessels, anterior-posterior great vessels, single coronaries, intramural coronaries. With all these things, considering the lot of variations, we can't be sure that the arterial switch and a double switch operation will give a good outcome. Mid-term outcomes so far, I have not put in the numbers here, but so far out not very better, and the long-term outcomes are not yet known. So whether simplifying the surgical options is the question, can't be sure about that as well. Now, this picture is just to represent what can be done with ccTGA. If there's a pediatric patient, this is for a pediatric patient. I'm not mentioning about an adolescent and an adult patient with ccTGA. If a pediatric patient presents with ccTGA, no significant anomalies, you can, if it's a good preconditioned left ventricle, can still go for a double switch. If it's presenting early in age and we are deciding upon going upon a double switch operation, go for an early double switch operation if you are experienced and confident about doing a good double switch operation. Now, it's a decompensated left ventricle morphologically. We can still go ahead with doing a banding because they are pediatric, less than 15 years of age. We can do a band, leave it for sufficient time, usually 6 months to 18 months of time, adequately prepare the LV, and if it is adequately prepared during regular evaluation, then embark upon a double switch operation. If even after pulmonary artery banding, the LV is not adequately prepared, either you decide upon continuing with medical management for this patient or going upon some other kind of repair or a physiological repair just for the sake of doing the surgery in these kids, which may not be optimal over the long run. If there is significant associated anomalies like VSD, if there is a small or restricted VSD, again go for either a pulmonary artery banding, preparation of LV, and then go for a double switch operation. If it is an unrestricted VSD, you either go for a much simpler procedure, do a Senning and a Rastelli, which can be a good bailout for these patients. If there is a pulmonary stenosis, if it is a resectable pulmonary subpulmonary stenosis, do a resection and then go ahead with the definitive surgical option. If the pulmonary stenosis is significant, either which is unresectable or pulmonary atresia and may require a pulmonary shunt in the early age. I have not gone to this palliative procedure. It's as same as any other palliative procedures. Go for a cavopulmonary shunt, either do a Senning Rastelli at a later age. Complex anatomy, if it is not correctable, maybe end up with a physiological repair or maybe a Fontan pathway or whatever. Now, this does not end the complex or problems with ccTGA. There are other problems associated, not just with surgery, even without surgery. Patients can have complete heart block over the age. As the age progresses, they can have complete heart block after surgery as well. Most of these patients require pacemakers, and they advise implanting permanent pacemakers after surgery, immediately after surgery in few patients as well, who have a predisposition to complete heart block. There is a role of then there is again the argument of whether univentricular pacing or biventricular pacing, right ventricular pacing, left ventricular pacing. I'm not going into the details of those things here. As the adolescent or elder patients are more in number, there is also a requirement of cardiac resynchronization therapy, which plays a significant role in managing problems with ccTGA. Ventricular assist devices play a great role in patients who have failing systemic right ventricle. The implanting a systemic right ventricular LVAD is a good option either for as a bridge to transplantation. However, implantation of a LVAD in a systemic right ventricle is not easier, but it can be done as well. Transplantation may be the option for long-term, maybe the long-term option either for failing hearts without surgery, or if the hearts do fail even after doing a physiological repair or an anatomical repair over the long-term duration. Pharmacological management plays a very important role in all these patients. Patients need to be on ACE inhibitors. The patients, due to tachycardias, arrhythmias, they may be on beta blockers, but we need to be cautious because starting on beta blockers for these patients can per se precipitate complete heart blocks. However, this is not something new to congenitally corrected TGA. They again will require pacemakers. What is the role of digoxin in improving ventricular function in these patients? Digoxin role is not proven, but maybe there is a role for improving the ventricular function by starting digoxin in these patients. Thank you. So I have avoided putting in numbers for the surgical options. There are a few papers which give lot of numbers, but I didn't feel it was necessary because whatever those numbers say, there is no set guideline for ccTGA or a perfect surgical pathway for ccTGA always. Thank you.
Thank you very much, Sri. It's, as always, very comprehensive and I think clear to understand. Any questions or comments from surgeons, cardiologists, intensivists? Could I ask you, Sri, if we know about the ccTGA, I mean in infancy, early infancy, what do you think, what is the optimal age for double switch if we go in for anatomical correction?
I don't know, maybe, I mean, I can't say the answer for that because I'm not.
Yeah, but from literature probably.
Yeah, there's no literature suggesting that the early double switch operation is an advantage because performing a double switch operation too early in the age will lead to more complications in the long term and the rather midterm outcomes. So we can't be sure about that is the best option. There is no paper that gives that doing a double switch operation early would be the best outcome. So I can't exactly say what is the age. Maybe Ram Dilioraf can add on.
You're unmuted on this.
Hi, Sri. Thank you very much. Stop.
There you go. Talk through that.
That's a good wake-up call for everybody, isn't it? Thank you, Sri. It was an excellent presentation, and it shows that this is a difficult group of patients. There are no solutions, easy solutions, and whatever you do, they are in trouble. In terms of the question, one thing is certain from literature is that late double switches are not good, especially over 10 to 15 years of age. And I remember in the recent teaching session, somebody presented a paper showing that over 25 kilos of weight or over 10 kilos of over 10 years of age are associated with bad outcomes. But most papers quote a median age around 3 to 4 years, something like that. Some do early, but about 3 to 5 years is probably appropriate in terms of size, body weight, and intracardiac repairs.
It's tricky, isn't it? Because I recall one of Dr. Peart's patients who he sat on, who was perfectly well with no associated lesions, absolutely fine, and then he refers him for repair at the age of 8, and this kid ended up with nothing but complications and a permanent pacemaker, and then he was kicking himself. And that's the difficulty. They can be so well, but as you say, if the papers suggest that very early repair and pretty late repair are bad, you have to go somewhere in the middle. But with a well child with no associated lesions,
No.
it's tricky, no?
This is for associated lesions. If there are no associated lesions, I think the best thing is to leave them alone. So they can go into 20, 30s and have a transplant rather than...
So you would leave them alone
I think so.
for a long time?
You mess around with them and then they have more complications. If they can have a decent quality of life.
What is the difficulty? So if you leave it, definitely they will need transplant 25-30.
Yeah.
Is that right thing to do when they are 12, 15 kilograms? Complicated surgeries, but if they do well, they're going to have kind of good life.
But what if they don't get a transplant at 25 or 30 and it's tricky, isn't it?
Yeah, that probably is a better option because they had a good quality of life. The hearts are not touched for 30 years before requiring a transplantation, rather than you try and intervene the operation. None of the double series, whether it's associated or unassociated, showed that kind of longevity without problems with good quality of life for 30 to 40 years. So I think the lesson comes out from many is that if there are no associated lesions, probably it's better to leave them alone.
Mm.
But if you have associated lesions, you are forced to do something.
Mm.
When you say associated with VSD,
VSD, pulmonary stenosis, pulmonary atresia.
Could you just ban them and sit on them for a while if they just had a VSD?
Yeah, but then what is the endpoint? What are you going to do? And that's why they say that if you leave them on PA ban for too late and then do it there.
If that is the case, then we could just do only physiological repair, just close the VSD. It's kind of give you the same, like, untouched ccTGA.
No, I mean, the literature shows that anatomical repair has better outcomes than physiological repair.
This is Nayan. This is an interesting, obviously, conundrum that has no easy answers, isn't it? I was just wondering, how do you approach this with families when, like Dr. Peart's patient, where he's well? Is this something? How do you approach the decision making? Is this something you offer to the families, or you direct them to one way or the other?
I don't know. Luckily, as a surgeon, we don't deal with them.
No, it's the cardiologists that have to make the call about whether they refer to the surgeons or not. I guess that's the tricky bit. What do you think, Aaron?
I mean, that's what I was thinking. I mean, generally, when they're around 13, 15, I will just bring them to the MDT and get everybody's opinion. And my feeling is it's better to have surgery so that they'll have a longer, good survival, but the wrong things other way. So I don't know what is right.
13 to 15 kilos.
Yeah. I mean, it is right. So when they are well, but they're well now, they're going to get into trouble soon. So
surgery has huge risks: mortality, morbidity, reoperations, re-interventions, and the quality of life as well. So it has a lot of implications.
As Sri said, there is nothing proven one way or the other, which is good and which is.
Yeah, I mean, there was a meta-analysis where they said, ideal age around 6 months to 4 years, going through that, and then ideal weight around 10 to 15 kilos to embark upon a definitive surgery, but mortality is around 7.5% up to, and then the event-free survival rate is around 70% at 10 years. So the numbers are not very promising to say, but it will improve as the surgical techniques and the management, intensive management or post-operative care or the post-follow-ups are better when we have more patients with the subset in the future time. More are surviving with double switch operations now, and hence maybe they will be showing a good outcome.
I have another question for the surgical team. Obviously, like most cardiac surgery, this is an eye-opener about the complexities involved in embarking on correcting these kind of lesions. But with regards to the AV node and the conduction pathways, are you actually able to see them, or when you open the heart, can you see where they are, or this is based on usual patterns? So, for example, Sri was saying that you try and take the stitches on the right ventricular side to avoid the pathway which are usually along the left ventricular side of the heart. Are these can you identify them, or you're going by usual patterns?
No, they just put a torch and then show it there, and then it all
Like runway lights.
No, Nayan, I mean, the conduction system is not visible in surgical field. So we just believe and trust what we were told and try and keep safe and then avoid that area. So it was an anatomical or histopathological description we have to go by. You don't see that in the operative field.
Okay, that's great. And you don't do any pre-op sort of assessment of there's no way of identifying this pre-op by doing electrophysiological studies or anything like that?
No, I think interestingly, all the hay with Manchester and Liverpool researchers, we have tried to map it out with a CT scan, but that we managed in histological specimens and etc. So we haven't really come that far to show it preoperatively with a mapping CT or anything like that. I don't think that technology is available.
Yeah.
Right. Okay. Interesting.
Okay, guys. This hard talk today has been the first of the agenda on the CACI. We need actually now to move on to the CACI link, which has been sent around. So who is interested in participating in the CACI, then I can switch off this and we'll meet in a second on the other one. Is that okay?
Yeah.
Yes.
Thank you very much for participation. Thank you, Sri.